Okay, well, next we're going to have Dr. Tillema give us a talk on MOGAD in children. So Dr. Tillema is one of our pediatric neuroimmunologists here at the Mayo Clinic. He sees all our children with MOGAD and is a wonderful collaborator, has a ton of experience, and is really world-renowned for his knowledge in neuroimmunology, especially when it comes to children and MOGAD. So we're looking forward to hearing his updates on MOGAD in children.
Well, this is the first time I'm sitting on a chair on a stage presenting, so there's a new one there too. Can everybody hear me? All right. So my name is Dr. Tillema. As you have seen, our group is a lot of international folks around there, and I come from the northern parts of the Netherlands, known for its tallest people in the world, as well as the most milk-producing cows in the world. The Holstein Friesian cows are from there also. So this is actually the area that we suspect is the origin of the Vikings rather than where the Vikings invaded. And here's a fun fact. Here's a sport, so most modes of transportation have been turned into sports, and here's one of them. My grandpa used to take me out doing this. So you go from the one field to the other in search of the field birds that lay their eggs there and hide in the grass. So if you really are good at that, is it going? Oh, that's too bad. Anyways, these guys jump 22 meters or 22 yards far on these sticks. So anyways, pediatric demyelinating disease has differences and overlap between adults, and that goes for any of the disorders. And many times one hears in pediatric, kids are not little adults, where the other way around, adults are sometimes little kids, is much more appropriate. But there are other diseases that we think of. So other diseases can have a possible acute onset, relapsing course, including genetic diseases or diseases that affect how you build up and break down your proteins and sugars and fats. And so we have a little bit more of a wider differential there, or a different differential, so thinking about different diagnoses than our adult colleagues. And part of that is that the white matter continues to mature. So myelin is not there, or almost not there at birth. And myelin is stiff, and we cannot go through the birth canal and form a cone-shaped head if the myelin is fully there. And so when babies are born, they barely have any, and it continues to form until you're about 25. And so part of the myelin is more exposed, including some of the glycoproteins than one would see in adults. And that is part why some of the presentations are different. So if you look at that, the whole brain volume increases, but actually if you look at your white matter volume, that goes up until its maximum at about 25 years of age. And so that's part of the perspective there. So we have immaturity of the nervous system, the myelination and the fragile balance of connections and networks still. So seizures and other disorders are much more common in the pediatric presentation, as we just heard. Then there's a neurodevelopmental immaturity. So not recognizing symptoms is not uncommon. We sometimes see preteens that come in with complete blindness in one eye, and nobody has even detected it until at the dinner table somebody's like, well, Johnny's still covering his one eye the whole time. And the second part is once you've been in the hospital and once you've had an attack, you may not want to go back to the hospital. There's some immaturity there in terms of how, again, how we approach that, and that's important for a relapse frequency too. And then the last part is that there's an immaturity of the immune system. So many times this happens after infections, rarely in vaccination, and there's some unknown environmental triggers still and some hormone effects on the immune system that we, for example, also see with multiple sclerosis, which after puberty is much more common in females, where before it's a ratio of 1-to-1 almost. And so whenever I tell the residents about this, I see some people from the 90s, when immaturity meets immaturity, really strange things happen, right? So many of the MTV generation may recognize this. And so strange things can happen. And so the example here is optic neuritis. So what we know from the optic neuritis treatment trial is that there are those symptoms that has already been reviewed a lot today, and that the majority of them have kind of a moderate or medium level of visual acuity loss, where in kids, if you look at that, the majority of them have 2200 or greater. And this is before MOG was known, and so probably a lot of those cases were actually MOGAD because they tend to have much more severe vision loss than in the adult population. Eye pain, as you've heard about, in kids, a third, two-thirds report of it because they just don't recognize it, especially in the young kids. So they'll say they have a headache. So over half of the patients have a headache. And the inability to differentiate that is not only there in children, but sometimes in their providers too. We see kids that come in with the diagnosis of a migraine, and they say, well, this vision loss wasn't just during the migraine. I've had it for 2 weeks now. And so you have to really be careful there. And the same thing goes there for optic disc swelling around 1/3 of the patients in that trial, where in kids that goes up to 2/3. So they have much more immune reaction and activation than most adults. And on the flip side, conversion to MS is much lower when you have this optic neuritis. Again, most likely just representing this pre-MOGAD kind of overall review of optic neuritis in kids. So the exact frequency is still in progress. We suspect about 3 in a million, and that is in keeping with what we see of all newcomers of demyelinating disease, which is about 1 in 100,000 per year. The majority of kids, when they have MOGAD, will have an ADEM attack. So acute disseminated encephalomyelitis, I'll just briefly review that. Then optic neuritis, and a small percentage have transverse myelitis, and then some of the other brainstem syndromes, the meningitis and unilateral meningitis can be all part of those more rare presentation, and that's in part age dependent. So this came from a nice overview study. So where ADEM is the biggest one in the very young kids, in older than 10 it becomes optic neuritis. And the diagnosis of ADEM, basically acute, that makes sense, disseminated, it's spread throughout, and the encephalomyelitis just means that it's in the brain and the spinal cord. So this was a diagnosis that was already well defined before the MOG antibodies came around, and actually was the first pediatric demyelinating disease that actually had criteria in 2012. And so the pieces there, just to kind of go through that, is that it needs to be subacute. It's not something that's been going on for a few years and gradually has worsened. You need to have multiple areas, not only on the MRI, but also in the clinical part. So often they have one arm weak, a seizure, different areas of the brain affected. They need to have encephalopathy, so that means that you're just really lethargic, sleepy, or even worse than that. And many kids will or may have a fever with this, so you always have to take that into consideration. The brain MRI has to be abnormal. You cannot have ADM with a normal MRI, and they typically are diffuse, large lesions, and they mostly happen in that white matter, so in the connecting fibers, but they also happen in the gray matter. And the majority of these actually do not relapse. And so this is what these spots look like. So a lot of I don't have a pointer, but the dark matter is or the dark spots are all the white matter, and those bright lesions are in there. And then in the top image on the left, that big one right in the middle there, that's actually the thalamus, and that's very common for kids to have inflammation. And then we've talked or heard some of the psychological, motor, cognitive, a lot of things actually have relay and pathways that go through there, so you can see a lot of different symptoms that can happen with that. And then the spinal cord, as we've heard about before too. The good part is that these tend to disappear. The top one is before, the bottom one is 3 months later or 6 months later, I don't fully recall, and it's completely back to normal. And that is not uncommon. So the treatment for any of the parts here are steroids, IVIG, and plasma exchange for the acute part. And then many of the kids are actually very highly steroid responsive, so they improve quickly with the steroids, and that's typically a telltale sign for us. And in case of the relapses, these are common after the steroids were stopped as one of the first spot, and then the long-term treatments are IVIG and less commonly other immunosuppressant medication. I've seen, as Dr. Chen mentioned, pretty much every patient that's come through our center in the last 12 years, and the majority do really, really well on IVIG. It's just sometimes it's hard to get and hard to get it approved. So when we do typically give it to kids if they have a relapsing course, and that's worldwide that's the recommendation. And most other countries do not give it in a monophasic course. But when we see a severe attack without good recovery, we tend to cover that too, because if there's another attack on top of that, then we're just worried that things may get even worse, of course. So if you have a severe attack with excellent recovery, we still tend to do an observing course in these kids. Again, IVIG is not covered. It typically takes a letter. I was just mentioning earlier, it's one of the things I have a template for, because that's how common it is for insurance companies to deny this. And the part of this, and this is even more difficult in pediatrics than in adults, that a lot of it is observation and experience. Trials are extremely difficult in children, and just to highlight in multiple sclerosis of all the, somewhere around 20 therapies that are approved right now, there's only one of them approved in kids. And it's not because we haven't used all of them, it's just that there's only one that completed the study that was satisfying the FDA. And the other part about when to give IVIG and to escalate therapy is that you have to really carefully make sure that an attack is true. So pseudo-relapses do occur, or very mild relapses occur, and you really need to jump to big immunosuppressant medications for kids that still have a long way to go with their immune system. And in other syndromes, especially when there are deficits in the brain from the attack, so for example seizures, they tend to recur because the damage was done because of the inflammation. The symptom of that is the seizure, and these seizures may keep itself in place too. So sometimes it's really hard to differentiate with 100% certainty whether it's something new, a new inflammation, or is this just basically a leftover part of it. In kids, relapses only happen in about 25%. There's some varying reports. The majority of them relapse within 1 year, the vast majority within 3. There are exceptions to this. There are times where we see that many years later, and so we inform patients about that. That could be the cause. That's false alarm. This is the interesting slide. It's a little bit busy for us clinicians, so we see this more often. But in the green, basically, you see from all the different presentations, they remain monophasic, so they have a single attack. So if you look on that right side, the majority of them have a single attack. And then after ADEM, you can go to multiphasic DEM, as that's called, or half of them go with optic neuritis. And if you have optic neuritis as a child, the chances that you have another attack is that it will be optic neuritis again too. So it helps with figuring those pieces out a little bit in clinic. Last part on MRI monitoring in kids, many times we need sedation. So most of the time in optic neuritis or transverse myelitis, we don't always do that. There's a typo in there, but and the brain, when the brain is involved, I tend to check 1 or 2 times. One time about 6 months after, and one time about 2 years later, just to check and see are there any unusual atypical part. Because with brain MRI, there is some overlap with MS, for example, and that's where I typically do one more after after children have gone through puberty, because we now know that a lot of the radiologically isolated, as we call it, only on the MRI, have good treatment options too as a young adult. So we tend to follow that up carefully when they have had brain involvement that way. And then the last part on MRI is that the future may hold better things. We think of MRI as these beautiful, sharp pictures, but actually the resolution is not much better than your, again, from the 90s, your flip phone from that time. The resolution of MRIs are not much better than that. And they get sharpened and they get done better. But if you think of, for example, the cortex, which is 2-3 millimeters thick, our pixels on the MRI are about 1 millimeter. So the very, very detailed pictures we still do not get, and we will never get, because this is the limitation of physics. It will go a little bit further, hopefully, unless if they find newer, better things. And I think that that's where the last part was, is that this is actually the first MRI. I sometimes like to pull this up. This was the first slice ever. Look at that young guy over there who's like afraid that he's gonna blow up or fly away there. And this was done at 11 p.m. and the first single image was done at 4:45 a.m. So why did they do it at night? Probably because they were afraid too that he was going to blow up. No, it probably took so much. It takes so much energy to get that done that they probably were only able to do that at night. And that's what that picture looked like. And this was the amazing detail where you see the lungs and the heart. So we've come a long way, because this is the first MRI of spots in multiple sclerosis in the mid-'80s. And so you can see if your neurologist has ever shown you any of the images, they've gotten much better, but there's a long way to go. And then the last part I wanted to mention, vaccination, a hot topic. I won't burn my fingers on it all too much, but did they cause it? It's really challenging. So in ADM, when they looked at this, less than 2 in 10 million were associated with one of the vaccines. When we see it happen, and it's within 2 weeks, up to 4 weeks, when we still see some suspicion, we feel that that's a good reason that that may have been the cause of that. And the CDC has ways, and there are ways for patients to get compensated for that if that's the case, et cetera. And then the second question that we typically get is, should I still vaccinate? I'm a believer in vaccines, so you can agree or disagree with me, but I think yes. And we do have some of the disclaimers, so if you have a clear association with that, then you avoid that vaccine. The other ones we tend to just continue. If there's question or concerns, pediatric immunology are often very knowledgeable on all the different things that they can help us with. And the approach that we have with any of the autoimmune, or at least that most of us have, is to at least wait up to a year with any further vaccines. And that goes the same for MOGAD. So typically, especially in the very young kids, we just hold off. They can wait a little bit and then they can catch up again. The flu vaccine, can you get that? It's always, and it remains a hot topic there, but typically at least waiting for a while seems to make sense. And I think that's all I had. Anyone? Yes, go ahead.
What is the one approved medication for MS in children?
Fingolimod.
Thank you.
Yep. Okay, good. Thank you.
Great. Thank you, Dr. Tillema.